So I am pleased to welcome Joy Briggs and Chin Kok, who are here to present on diabetes management and technology updates. So a little bio about Joy. Joy celebrated 20 years of nursing in 2023 and has worked in various positions. Early in her career, she worked in an adult care on a surgical and oncology floor. And starting in 2011, she left the bedside to pursue nursing leadership. Since then, she has worked as a nurse manager, both inpatient and in the ambulatory setting. In 2016, her son was diagnosed with type 1 diabetes, which led Joy to join the team at Seattle Children's. She is currently the business operations manager for the endocrinology team and remains passionate about diabetes education for nurses and patients alike. Chin has been with Seattle Children's for over 7 years. His involvement in diabetes was initially based on curiosity. He understands the daily routine and the amount of effort and energy required to manage the chronic condition. Over time, he came to understand the hardship, frustration, burnout, and the mental fatigue of what this chronic condition brings. He is equally amazed and impressed by the number of dedicated people who are involved and their perseverance, in caring for the child. It truly is a remarkable team effort. Chin has participated in various diabetes summer camps, including 2 years running the Jordan Morris Foundation Summer Camp for type 1 diabetes. It is a wonderful sight to see the children with diabetes thriving and flourishing in the communities. Welcome to Joy and Chin. Please take it away.
Thank you. First of all, welcome to everybody, and I hope that our topic right after lunch is enough to keep you guys awake and we're not too boring. As mentioned, I'm Joy, and Chin is with me as well. We do not have anything to disclose for our presentation today, no conflicts of interest, etc., etc. All right, so we're going to be talking, we've divided our presentation kind of into two. So the first part of our conversation, we're going to talk about diabetes management and care, talk a lot about how that is done in the community and at schools. We're going to do some review over diabetes basics and some tips and tricks about how to be successful in managing diabetes. And then we're going to spend the second half of our presentation talking about the technology that's out there, because that's one of the biggest challenges in diabetes is all of the advancements and changes, and 2023 saw a whole lot of change in diabetes. So with that, I'm going to turn it over to Chin and let him take it away.
All right, I hope everyone can see this slide. Good afternoon, everyone. My name is Chin. I am going to talk about the school management part of diabetes. What you see on your screen here to the left side is the standard release of information form. Typically, this is the one that we obtain the signature from the parents saying that, hey, it's okay for us to exchange information with the school nurse. And the care plan is usually created during the summer months when the students will come in for the usual clinic visit, right? Some of these families would definitely need reminders to book that appointment before the school ends, because once the school starts again in September, many of them don't have this, and then the school nurses will be nagging them to get this going, and then we will have to backtrack and figure out what that care plan is for them. So during the clinic visit, we will ask the families if the students has transitioned to either elementary, middle school, high school, or just simply moved to a new school district. And if so, this is when we will usually ask the families, the parents in this case, to sign that new release of information. Now, once the clinic visit is over, the care plan can be completed. So how this is distributed comes in several forms. The provider either prints the hard copy right on the spot and just simply hand it to the parents, or they can simply generate a digital copy in the MyChart. They can retrieve it later. Or we can also, if we know the school nurse's fax number, we can also fax it to them. And if the family members don't have access to MyChart, we'll just simply mail a hard copy to them too. Now, on the copy that you see on the right side, it is a typical sample of what a school care plan looks like. It encompasses all the standard dosing information, how to treat any hypoglycemia episodes, treating the hyperglycemia, including monitoring the ketone levels, and calling the parents if the patient has any moderate or large ketone, because typically in this case, the school nurses, they're not responsible for managing the child's ketone if it's moderate or large. Usually it's a parent that would take over, and then the parents would then reach out to us if they need any assistance in managing it. In addition to the care plan, embedded into the care plan, we also will show the math formula of how the dosing is calculated so the school nurses can verify that and the correct amount of dosing. And also, under what scenario would the school nurses be monitoring the child or the student's blood glucose level? This is including using the continuous glucose monitoring device or just simply using the old-fashioned glucometer and finger poke method. The new care plan is not necessarily, we don't need to constantly keep adjusting and updating the school care plan if the dosing is within plus or minus 20% from the original dosing. And usually this is agreed upon between the school nurse and the family members. And usually, unless something really drastically or significantly change or anything different that we realize during the next clinic visit, then we'll update the school care plan and fax it to the school nurses. Any other different scenario will be like the child is really having a tough time getting their appropriate doses at home, and then they need the school nurse to help in, and then therefore we'll add some content in within the school care plan indicating what type of help the child needs. For example, if the child is just having a tough time getting their long-acting insulin at bedtime, then we'll just say, hey, when you go to school, you get it first thing in the morning, and the school nurses will help the child or the students to get that dosing done. We can go to the next slide. Okay, what you see here is a very typical example of what that dosing looks like. So I said earlier, in the care plan, you have the math formula, but not all families will use the math formula to figure out the dosing for their child. So we typically will hand them this old dosing table method. Think of it as a sliding scale for the adults. This is the equivalent of it. And you can see the left column, which is for food, and the right column for correcting the high blood glucose. So sometimes the school nurse will use this copy too to figure out the appropriate dosing for the child too. Next slide. So before I go into this diabetes supplies, I want to acknowledge the importance and the value of the school nurses, because you guys do such an amazing job at the school. You see it firsthand, whether the students is able to do it or not. You see the challenges that they experience. So it truly is a teamwork, and we really appreciate your involvement in this. And it's usually, we hear it from you that there's a concern, right? You're seeing something different than what the families are reporting, and we get it, we get the both sides of the story. So we do appreciate you guys. All right, so now let's talk about the diabetes supplies. So a lot of times the school nurses will request diabetes supplies from the families. I want to talk about this, as you may not know this. Many families are restricted by the quantity of the supplies they can get because of their insurance. This is especially true for those who are on state insurance plan. They're only limited to 100, 200, or 50, whatever that is. And so it's very hard for them to share the supplies with the school nurses. And also, many of these families also don't understand how to access their diabetes supplies or how to ask for them through the pharmacy. So sometimes we have to educate them. Now, On the flip side to that, though, because these supplies are obtained on a monthly basis, they may not necessarily use all of them, right? And then they can always renew them and get new supplies every month. So in some ways, they can actually share some of the stuff with the school nurses. For example, they can get a glucometer, a new one, the following month, and they can just simply give it to the school nurses. And then any test strips, Lancet, device, all of that, they can just hand it to the school nurse, and the school nurse can have it on standby whenever they need it, right? This is especially true when the students transition to the continuous glucose monitoring device. Therefore, they don't necessarily need to use the glucometer and the test strips anymore. We can move on to the next slide. Okay, this is what I'm talking about. Joy will dive more into this continuous glucose monitoring device. It is super, super convenient because then you don't need to do the finger poke anymore, and you can just simply monitor the students' glucose level through either the phone app or iPad if provided by the school district. It's super convenient. And again, then the families can then share the test strips and the glucometer with the school nurse. Some school nurses, I'm not sure the criteria. Some school nurses will actually ask the family to give extra continuous glucose monitoring device to the school. This is particularly challenging because, again, they are limited to the amount that they're given dictated by the pharmacy and particularly the insurance, right? So the default to that is they will have to use the finger poke and glucometer method unless the families can actually afford to pay out of their own pocket and get the extra ones and then hand it to the school nurse. Next slide, please. Okay, this is again very true with the insulin. So depending on the type of insulin, whether they get the pen or the vial, in this case, a lot of times they will get the pen form, right? They're given a standard box of 5 pens. And then therefore the family can share 1 pen with the school nurse. But again, depending on the pharmacy they use, sometimes the pharmacy will not give them a box of 5. They might be giving them 1 or 2 pens, and then they can't get the whole supply, and then they cannot share it. And then they will have to wait till the next month. Or sometimes the student will use up a lot more because their insulin need is greater, and then therefore they cannot share it with the school nurses. So it really depends on the situation. Next slide. Okay, so now this is quite common at the school setting, right? What happens when the child is experiencing hyperglycemia, and now you got to check for the urine ketones. So the urine ketone test strips are very easy to obtain because, again, it is a monthly supply. So the families can always go to the pharmacy the next month and get a box and hand the school nurse a brand new box, and you can just use it from there. And it doesn't happen all the time, so it's easy to have it on file. And please refer to the school care plan of how to manage or how to check for the ketone, right? Again, if it's moderate or large, you're just simply calling the parents and have them pick up their child and take it home. And then the parents will reach out to us, and then we'll communicate with the parents on what to do next, right? Let's see. And then, of course, do encourage fluid intake just to get the child to pee out all that high ketone level that might be building up in their system. Okay, next slide. Okay, glucagon. This is for severe hypoglycemia event where the child becomes unconscious, having a seizure, etc., etc. We really hope it doesn't come to this, but regardless, the child should be able to give the school nurse 1 extra set of this because they're given 2, 1 for home and 1 for school. But as I mentioned earlier, it really depends on the type of insurance coverage that they get. Typically, the kids that are on state insurance plan, they get the one that you see at the very top in that red box. It is a intramuscular injection form. So it does require a bit of a mixing. And we also understand not every school has a full-time nurse, and then therefore you need to find a designated someone who's gone through the training to be able to give this injection if needed. The only other way that we can override this and get then the nasal form, which is the one that you see in the yellow canister to the right, is we need to do this, what we call a prior authorization. We need to justify why the student needs this nasal format instead of the IM injection. And then hopefully the insurance will approve it. And the one that you see at the bottom where it says GVO, that is another form, which is also a much simpler method, right? You basically just open up that red cap, inject it like an EpiPen, and then call it good. And then obviously call 911. But again, do know that not all families can have that ease of access to the nasal one, the Baqsimi, which is the yellow canister that you see in front of you. And that is my portion of the presentation. I'm going to let Joy take over. Thank you. Oh, yes.
There are some questions in the chat. I'm going to actually, Chin, if you can get to the chat and answer a couple of the questions that are there that are pertain to yours.
Yes.
And then if you want to monitor while I'm doing it, if there's anything that you can jump in and answer, I'll let you. But does anybody have any questions before I jump in? Okay. All right. Well, then I'm going to move on. Just before Chin, before I dive into the technology piece, this slide here is the best way to get a hold of us, particularly if you have a child and you're not entirely sure what to do. As long as we have a release of information in place to talk with you, you are certainly welcome to give us a call about specific children, and we can give you advice on that child if we have an ROI in place. You can also just call us if you have a general question about diabetes management. We can talk to you in high levels about diabetes management and in those things. So, don't feel if you're really stuck on a situation and you want to talk hypotheticals, also please just give us a call and we can talk hypothetical situations as well. So, okay. As Chin alluded to, I'm going to go a little bit deeper into CGM. For those of you who attended this conference last year, this may sound familiar, but I always think it's a good idea, especially since it's a large group of people. So a reminder of what a continuous glucose monitor is. So continuous glucose monitor actually measures interstitial fluid to determine current glucose level and identifies a trend. So with a glucose monitor, a continuous glucose monitor, you can see if blood sugar is rising or falling and how fast it's rising or falling. And that is super important. And I did see a comment in the chat about CGM and finger sticks. If a child is wearing a CGM, and all of the CGMs on the market now are FDA approved to dose off of, you do not need to finger stick and in addition. So if they are wearing a CGM, you can go ahead and use that as the source of truth. And we strongly encourage you to do so. The benefit of a CGM is not using finger sticks, and it just makes it so much easier on the kid. That said, there are times when it is appropriate to check a finger stick, and that includes if the symptoms do not match the number, or if you're really, really high or suspect really, really low, but symptoms don't match the number is the biggest thing. And this does happen where you'll have a kid whose CGM is saying it's 50, but they look perfectly fine. Take a finger stick and see what is really, truly going on. But otherwise, use the CGM as your source of truth. The CGMs that are all on the market now allow for sharing with parents, and so you can also share most of the products on the market. You can have several different people following. So if you are managing a child with diabetes, I encourage you to see if you can get an iPad or something so that you can monitor trends and have alarms set so that you can be aware of what's going on. And then the other thing about CGMs is it allows for decisions to be made based on time and range rather than A1C, and I'm going to talk about that on the next slide. So time and range is a system of monitoring diabetes success, and it's a little bit easier to use and understand than A1C. This graph on the top right here, the many faces, the A1C, you can see there that an A1C of 7% can have a lot of variability, including many peaks and valleys, many highs and lows, as well as an average time in range. So by looking at time in range, you get a better sense of control. So the closer to 100%, the more likely you're within that 70 to 120, which is the standard blood sugar range that we want everybody to be at, and pretty much no one is. There are few, but not a whole lot of people spend a lot of time in range at 100%. So our goal is to have at least 70% of the day be in range between 70 and 180, with less than 4% below 70, and then we want to minimize our time above 180. So CGM is the foundation for automatic insulin delivery, and I'm going to use this in a couple of different slides. And so automatic insulin delivery is going to be what I'm going to probably spend the majority of my time talking about today. So automated insulin delivery is the it phrase to use for systems of insulin delivery in which a CGM is integrated with an insulin pump. And the insulin pump is then using a mathematical algorithm or several algorithms to adjust insulin delivery based on what blood sugar is doing. So the advantages of using an automatic insulin delivery system is that it helps protect against hypoglycemic events, especially severe hypoglycemic events, but it also automatically increases insulin to reduce hyperglycemic events. So we are now using a system that helps bring that time in range in, and it helps minimize the interaction and burden on the patient. Automatic insulin delivery is what used to be called closed hybrid loop technology, and you may see both used interchangeably. This is another graph that kind of shows the same thing that I showed on the prior slide, in which the system will have a low glucose suspend where the insulin will be stopped, and no insulin will be given to the patient if the blood sugar is at a certain level. It can also predict if the patient is going to go low. So maybe they're 120 with double arrows going down, and it's going to back off on insulin so that they don't go low. And then the algorithm will also then increase insulin delivery as blood sugars are rising. So we're at hybrid closed loop now. The goal in research is continuing to go towards a fully automated closed loop. And there are some new systems on the market that are closer than we've ever been. And I'm going to talk about those in a bit. And then ideally, of course, we're going to have an artificial pancreas that does everything, and nobody's going to have to worry about diabetes ever again. And that's 5 years away. And it's been 5 years away for the last 25 years. So, we're getting closer, right? Okay, so the benefit of closed loop or automated insulin delivery allows for that tighter blood glucose control, allows for increased time in range, and really the biggest advantage is to reduce the burden on the patient and to make it easier for the patient and the family to have less to do and worry about their diabetes. And the more we can take away that burden, the better it is for overall mental health and really overall success for diabetes management. And again, I've said this before, but it'll minimize hypoglycemic events. It'll correct for hyperglycemia. And what we find is that patients who start on automatic systems within the first year of diagnosis have long-term better outcomes than families that don't. So with that, there are some challenges and some concerns with all this technology. One of the biggest ones that we run into is that each system has specific compatibility requirements. So that includes what type of CGM can be used with each system, what phones are compatible or not compatible. So the systems that are on the market today still do require interaction with the device. And so you do have to have some awareness of what's happening in the body. It also can take a significant time for an insulin pump to be approved. We are working very hard to increase that, and our goal is to get patients on pumps as soon as possible. But in America, that is still a challenge because we are still fighting with the insurance companies on those. And obviously, you still have to wear a device. So it is not like getting an implant or anything. You are wearing something foreign on your body, and that comes with challenges. And then one of the biggest challenges on our end is that all of these systems work differently, and that increases burden on the healthcare providers because we have to know the ins and outs of each system and how it works and how it interacts and what does that mean, and so that we can best advise our patients on which systems are best for them. So that can be quite challenging, especially in a year like this last year that we have. So, and the rest of my presentation is going to I'm going to go through this fairly quickly, but this is kind of where we are with diabetes technology today. So there are 4 systems that are currently on the market. They are all a little bit different. And this slide, honestly, is our godsend. We call it the Panther handout. Talks about what system does what and what are the benefits of each system. But these are the 4 systems that are currently on the market. The MiniMed 780 and the iLet Bionic Pancreas were new in 2023. And so I'm going to spend a little bit more time on those 2 products, but I am going to review Omnipod 5 and Tandem Control IQ pretty quickly. So I'm going to start with the Omnipod. This is probably our most popular system right now. And the reason why it's our most popular system is that it is tubeless, which means that you are not connected with a tether to your body with the pump. So you wear a pod, and then that pod communicates with a personal device or a cell phone and allows for that communication to take place. It works with our Dexcom G6. It is an automated insulin delivery system that adjusts basal rates and works to keep blood sugar in range. The pod and the CGM do need to be within line of sight, so that can be a challenge, meaning that if your pod is on your right side, your CGM should be on your right side as well. So you have to be aware of where each thing is on your body. We have not yet gotten to a place with any of these systems where the CGM and the pump site itself are connected. So every one of these systems does require wearing 2 different pieces of equipment. The Omnipod 5 does take some time to learn that individual systems. It often takes 2 to 3 pod changes to start working efficiently and effectively. And what that means is that, and those pods are changed every 2 to 3 days. So it takes 2 to 3 weeks for the system to really start optimizing and really start learning that child and really work at its most effectively. So it does require a lot of interaction with parents between now and then. Tandem Control IQ is the next pump on this system. And I'm not reading this stuff on this slide. I actually took these slides from our pump information class. So it's more information than most of you really need to know. But so I'm just hitting the highlights here. Tandem Control IQ is great in that it is constantly looking at what is happening with the CGM readings and is predicting what is happening 30 minutes from now. And so it is automatically adjusting the insulin basal rates based on those CGM readings to help try and keep that blood glucose steady at sometime in range. Another advantage of the Control IQ is that it will give a 60% correction bolus if the blood sugar is above 180, and it will do that every hour. So what we find with the kids on this system is that they'll forget to bolus for their meals, knowing that the system will keep up or try to keep up. The Control IQ also has an exercise mode. So if there's activity such as PE or they're going camping or whatever, we can increase the target to 140 to 160 to help reduce the likelihood of a hypoglycemic event. And then it also has a sleep mode, which increases basal rates, but will not give those automatic correction boluses overnight to help keep that blood glucose very tightly controlled between 112 and 120. Most of the kids that we see on Control IQ usually have really good control overnight, and it's during the day that we struggle with control. So both the Tandem and the Omnipod have been on the market for the last couple of years. The Tandem is the oldest system on the market. It was released in 2020, and then all the rest of them have been released since 2022. And there is a new product coming for Tandem, and I'm going to save that one for last. But the next one is a Medtronic 780G. This was a huge advance in technology this last year. Medtronic is one of the oldest systems that has been around. Medtronic has had insulin pumps for a couple decades, but this is the first system that really uses some meal bolus technology, and I'll talk about that in the next slide. This system, again, it learns your insulin needs over the first couple of days. So it's looking at CGM readings and making corrections every 5 minutes. It is allowing you, it also has a temp target for exercise. It does not have a sleep mode. The other thing about the Medtronic system that is different than every other system is that Medtronic has a proprietary CGM called the Guardian, and it only will work with that Guardian sensor. So that is something that is considered as families are looking at what system is, the CGM component of that, whereas all of the other systems use a Dexcom and can mix and match. And anyway, that's more than you guys probably need to know. But one of the coolest thing is that the Medtronic 780G has meal detection technology, which means that it is using the glucose trends to detect if a person did not bolus for their meal. Now, ideally, we are still saying that you should bolus for every meal, meaning I'm going to eat a meal, I'm going to tell the system I am eating a meal, and I'm going to have it give carb coverage. But if you miss a meal with the Medtronic, it's going to detect that you have a sudden influx of a sudden rise in blood sugar, and it's going to automatically increase the rate of insulin delivery to a stronger level than it would otherwise, because it's going, I think you ate and didn't tell me. This is really super helpful because it helps keep that glycemic control at a smaller wave. And it's super helpful and, again, reduces that burden. And so I'm just now noticing there is a error on the slide in terms of spelling, so it distracted me there. But it's really cool, and we're finding that we get a lot of really good outcomes with this system. It is still really new. It only came out this, I think, late summer. So, but we are seeing kids on this and that are doing very, very well. The final system that came out, in fact, this system just launched in November here in the Northwest. It was FDA approved in May of last year, is the Beta Bionic iLet. This is the first pump on the market where it is pretty much as hands-off as you possibly can get. Again, this works with the Dexcom G6 or G7, and it basically, all you do with this system is announce a meal. You do not enter carbs. You do not give a bolus for corrections. You are just literally saying, I am eating, and I am eating what I usually eat. I am eating more than what I usually eat. I am eating less than what I usually eat. And that is all you do with this pump, and it does all the rest. It has 3 complicated algorithms that predict all of that stuff. It is looking at continuous glucose monitoring every 2 minutes and making decisions based on that. And so this is really exciting. There's a lot of things that we need to consider with this pump. So it is just now starting to be prescribed more regularly. And going back to that school care plan, because literally all you do is tell it that you're eating, it makes it a lot more complicated than you might think when we're talking to school nurses and we're like, yeah, don't do anything with this pump. What do you mean don't do anything with this pump? Don't do anything with this pump. So we're still trying to figure some of those things out. And, with that, what happens when there are ketones, and some of those things we are addressing on the clinic end. So, but again, to reiterate what Chin said earlier, if a child has moderate or large ketones at schools, it is not the school nurse's responsibility to handle that. I understand that there are situations where you may not be in a choice to do that, but the first thing you need to do is call the parents. We train the parents on how to manage ketones, and it is their responsibility to do so. If you are in a situation where you have to, we ask you to please call us and we will walk you through what you need to do. So the final pump I wanted to talk about, this pump is actually going to be launching in February, late February, March, and it's the Mobi. It is essentially that tandem control IQ in a really teeny tiny package. It will interact only with a phone device. It will not have a separate device to give dosing off of. So it's just this little teeny tiny pump. And,
No.
It is super cute and a phone. And so it is still tubed. but it is more flexible. It's about the same size as the Omnipod, but it can be worn more places on the body. And because you're using the phone, for people who really don't want to announce that they have type 1, it is a little bit more discreet. So we find that to be pretty cool. Since it hasn't launched yet, I can't really talk about the clinical outcomes of it, but since it is using Control-IQ technology, we expect it to be roughly the same as what the Tandem is doing now. So why did I just spend the last 10 or 15 minutes going over this? And why do you need to know about all the systems that are on the market? Again, pump systems mean less work for you. And so at least understanding at a high level what pumps are on the market can give you a basic understanding of like, oh yeah, it's an automatic insulin system. I shouldn't have to do much with it. It's really the parent or the child that is doing that. It will help direct you on what actions to take, or the patient, especially like with the iLet where you're announcing meals, or Control-IQ when it's alarming at you because it's suspending and you're going to go low. Again, I know we said this a lot, but call your parents first. And if they aren't able to help, then call us, or you can't get a hold of them, get a hold of us. So, I mean, as we wrap up here, and we're going to have plenty of time for questions and hope you have a lot of them. We just want to let you know that diabetes really has a lot of moving parts, and Chin and I could probably take the entire conference to talk to you about diabetes and all the nuances and ins and outs and explain everything that there is to do about diabetes. But the technology that's on the market is designed to make our lives easier. And we find that, especially in this last year, we're starting to get there. And the thing with easier technology is it's uncomfortable because now all of a sudden we're more hands-off than we've ever been, and it makes it a little bit harder to explain to people. If you were to ask me like exactly how do the algorithms work, I couldn't answer that question. I don't know. That's math. I went to nursing school. I'm not a mathematician, but at the same time, we need to understand at a high level what we're seeing with those trends and the reports that we get about insulin delivery. So the endocrine team is here to help. We want to be able to help you. We want to be able to support you. We have a high number of patients, and I also recognize that getting a hold of us can be challenging. But we are here and we want to be a resource for you. So with that, I'm going to open it up to questions. I know I talked real fast. We'll take a look at the chat and see what you have. And again, Chin and I are happy to jump in and answer whatever questions. And it doesn't have to be what we talked about. If it's about diabetes, we can probably give you an answer. And I am going to stop sharing. Okay. So I see a couple of questions about insulin. Just to remind everybody, insulin can be at room temperature for 30 days. Obviously, if you're going to have it as a backup, you should keep it in the fridge, but you can go ahead and store that up to 30 days. I see here school orders allow for corrections with the pump at meals and snacks. Chin, do you want to talk about that? I think we do talk about, so there's a difference between a correction and a coverage.
Right. I think I briefly answered that. It's really if the child do need additional corrections, sometimes we need to find out, does this happen a lot? Does this happen all the time? What's going on? If it's just 1 or 2 times, then we don't need to again modify the school care plan just to show that the child needs it. It's really a judgment nursing call. Again, if this is a repeated, recurring theme, we tend to. I would encourage the school nurse to reach out to us and see, hey, maybe we need to adjust the school time dosing needs.
So there's a good question about if for families or kids who are shy about pumps and so forth, and the family can't afford a smartphone, does insurance help cover that? So insurance does not necessarily Medicaid has a program for technology for those on state insurance, and we actually have a scholarship fund specifically for families who cannot get access to technology that we tap into that helps provide families with phones and other technology that they may need to have. Is there any plans to have a diabetes navigator? Gosh, I sure wish there was. Yes, we would love to have a diabetes navigator, but as far as I know, there is no plan from the hospital to get one. Do most insurance cover pumps? Yes, every insurance company will cover insulin pumps. The question is which one and how long do we have to work for it to get it? And Omnipod is the only tubeless pump, truly tubeless pump on the market, yes. When patients are coming into the hospital for a surgery, we typically have them tested on our machines pre-op. Are we needing to do this or to trust the machines? That is a complicated question. We do have to follow protocol, which for right now is, yes, you need to test on the Abbott system. The reason for that is the glucometer at the hospitals automatically upload into Epic, where the CGMs do not. There's a lot of work going on behind the scenes around perioperative care right now in diabetes management, and we are working to make that a little bit more reliant on the technology at hand. And I suspect that over this next year, we're going to see a lot of change in that and a lot more reliance on the technology that families are wearing. As a clinic nurse who's had to fill out prior auths for CGMs and pumps, any tips and tricks for getting them approved? Phrases to use. Insurances really like to see hypoglycemic excursions and proof of 30-day blood glucose logs. That's really the best way. If you can show that a family has worn a sensor for, if you can give them samples and they can wear that for 30 days, that's 30 days of data, or they have to test their blood sugar 4 times a day for 30 days in order to show that, and or have hypoglycemic excursion. So if you can say they run low 3 to 4 times a week under 60, you'll get it approved. So those are some things that you can say. Yeah, please strongly encourage families to get care plans the last 2 weeks of school. We agree. We start actually pushing families to get their care plans updated in May. So before school is ever getting out, we are pushing for care plans. It is a heavy burden on us. We currently have 2,900 diabetic kids. So that's 2,900 care plans we are doing over the course of the summer. And we are pushing, I know some of the nurses are doing up to 30 or 40 care plans a day, trying to get those done during that time frame. So the sooner we can get them done, the sooner, yeah, we're with you there. We want them done. Are telehealth sessions with a children's specialist available for students with diabetes? Yes, we want to see every patient in person at least once a year, but we do have telehealth available. And I'm doing all the talking, Chin, so. Is it standard for all diabetics to use an insulin pump and CGM? That is the gold standard of treatment, yes. Does T-Connect have a share app or only with one device? Right now, I think I would want more clarification on that. So T-Connect has a web-based platform that you can use to see your child's data and information, but it's not the same as being able to follow what the pump is doing in real time. Chin, do you want to expand on that?
No, I'm not sure I know how to answer that question.
So, how do you help students and families understand and buy into the importance of staying in their target zone to help prevent the long-term effects of diabetes and not just wait to push a button when things get, quote, really bad? I think that in the bigger picture, over the course of the lifetime, the highest A1Cs are between the ages of 15 and 21. And it is really, really challenging to get that age range in particular in control. And there's a lot of reasons why. Puberty and hormones affect blood sugar. Puberty and hormones affect attitude. I think that there's a lot of things. And that is what we do a lot of, is behavior management and encouragement. And I think that the best thing, one of the strategies that I've heard that works really well is What's one thing that you can and are willing to control? If there's just one thing, what can I help you? What one thing can I help you do? And as the mother of a teenager with diabetes, sometimes that's difficult. So how do we get information on this scholarship? Emily, we can connect offline and I can get some information to you on that.
I just want to quickly go back to what Joy said earlier about the teenagers' management on their diabetes care and all whatnot. And this is why it's so important to have you guys, the school nurses, involved in letting us know, right? Because sometimes we only see them in the clinics and then the families don't report anything to us and we have no idea what's going on until you guys reach out to us. And then we come to find out there's all these XYZ issues that the students is experiencing. And then depending on the severity of it or the needs of it, a lot of times we will also set up like a full team visit where not only we'll have the provider, we have the social worker and the dietitian, a full team visit for the student.
Yes, we will have care conferences with schools. Absolutely. Nurse from CBDC have bone marrow transplants with insulin pumps. We actually talked about being able to get inpatient nurses access to some of the diabetes technology platforms. One of my long-term goals, I like to say we want one ring to rule them all, but the reality is each system has its own platform, and so there are about 5 different platforms that you would need access to. It is as simple as putting in a ServiceNow ticket, but it is a lot harder in terms of being able to interpret and understand what that data means. And so the best way is really to reach out to one of our diabetes specialists and have them help you if there's some concern about insulin variants. Question about overcoming barriers to getting Baqsimi versus IM glucagon. That is really up to insurance companies. And unfortunately, the state plans really, really don't like Baqsimi. And we have to do usually a PA denial and a letter of medical necessity to get Baqsimi approved on the state plans. It's very uncomfortable to have hidden data on very complex, acutely ill patients, and in that highly stressful situation, it feels unfair to be relying on parents to manage and ensure it's functioning properly. I don't disagree with that. Unfortunately, I'm not sure how to overcome that barrier with each system, unless there was one system that everybody was on. I don't know that we're ever going to get to a point where we can have a system that just plugs into the hospital record and be able to provide real-time data. Do we have any tips for middle schoolers who have diabetes but are also behavioral and such behaviors affect their diabetes care in a negative way? Examples include restricting intake, skipping meals on purpose, lying about food intake, lying about numbers. Chin, you want to take that one?
It all goes back to the school nurse, right? A lot of times, like I said earlier, we don't know and the families don't report that. So that's why we rely so much on the school nurses to inform us. And then we get the whole team involved, right? Again, with the social worker, the dietitian and all that stuff. And also going back to what Joy was referring to, right? What is the one thing that you want to do, right? The one thing that you can control, that you think meaning the child, can do well. And then we just start with the small goal, right? The small, smart goal, and then go from there, because sometimes it's just too overwhelming to try to address every single aspect of the child's diabetes care.
Yeah, and those are hard for us too. So as the endocrine clinic preparing for the use of Afrezza, which is the inhaled insulin, if approved for under age 18, we are running the clinical trial in the research center right now. So that's a pretty small trial that's being run out of the CRC. We have not been preparing for Afrezza because as of right now, it is only approved for 18 and older. Dr. Malik, who's one of the principal investigators on that study, is integral. And with every new technology, we end up learning about it as it starts to roll out. So first we would need to get it FDA approved, and then we would need to know when it's going to launch and how it would work in those younger populations. But we will cross that bridge, and we hope it comes because it's pretty cool. With a medically fragile child, would the use of a CGM be appropriate to help home care school nurses monitor a kid's level in their care? 129%. Yes. CGM can only help with diabetes management. And so finger sticks versus glucose and the more accurate number. So this is where I'm going to give my little talk about interstitial fluid versus blood level. Yes, blood is considered the gold standard and the most accurate, but the interstitial fluid is still an accurate number. And you got to think about it as a roller coaster, right? So if the blood sugar is going up, you're going to get a higher number from the blood than you will from the interstitial fluid, but the interstitial fluid is still climbing. And likewise, when it's going down, same thing. The interstitial fluid is going to read higher than the blood glucose is. It is still accurate. The percentage that we use for the hospital is 12%. I know that there was a study that determined that is. So if the blood sugar and the CGM are within a 12% range, then it's considered accurate. But the standard that is used is called the MARD. And the MARD, which is like how accurate it is compared to, I can't really describe it very well, but the MARD for CGMs are as good, if not better, than the glucometers. And the MARD is like comparing the same glucometer to each other, are you going to get the same number? So glucometers are not as accurate as you think they are. And if you were to use 3 different brands of glucometers, you're going to get 3 wildly different numbers. So the truest accurate result is a serum blood glucose level, and you're not going to do that on every kid. So is it possible that care orders will be able to list both glucagon and intranasal? I have to get corrected orders many times because the family wants both. I think that's a reasonable thing we can consider if the insurance will cover both. Is there a channel for school nurses to communicate with provider easier than phone calls? For example, emails, leave messages through the website. If it's for some minor issues or routine reports for student status. Not at the moment, and this is, again, a challenge of healthcare. We do have an email, but we don't monitor it anymore because we really ask that the communication go through my chart. There is, if you have not heard of DISH, it is Diabetes Inside School Health. That is a Zoom meeting once a month on the 3rd Wednesday afternoons. You can check out their website. I think it's like, you can just type in Washington State DISH and you'll get it. That is a venue specifically designed for school nurses, and topics in there are covered that specifically pertain to school there. And I would love to connect with a couple of the school nurses on how we can better communicate with you. Because I agree, we want to collaborate with you and we want to be more collaborative with you.
In regards to that too, a lot of times, at least the school nurses that I've spoken to, right, you guys will show us, again, let us know things that we don't normally know or see. And then you guys will fax us the students' blood glucose logs. And then we can like compare and contrast what they have at home and then inform the provider during the next clinical visit. And that is like super, super valuable to us to help the students too.
Absolutely. And the last time we updated our school orders, we did get a couple of school nurses involved to get their opinion on what might make it easier, because I mean, the reality is our care plan's 12 pages long. So, anything we can do to make it easier.
Wait, sorry, Joy, did we answer the question about the teens that are reluctant to check the urine ketone, or did I skip that?
I think we skipped that.
Okay, our apologies. Yeah, this is another behavioral issue, right? Very challenging to do so. The only thing we can probably say is, do let us know, right? At least we can then be the bridge to communicate between the parents, the child, and you guys, the school nurses, and just to figure out a successful plan, to figure out why they don't want to do it in the first place, right? We need to find out the reason why they don't want to do it, and then work from there.
Exactly. We have a few minutes left. Are there any other questions? Yes, the email in the past, it isn't currently monitored. That is correct. We do not check it's mostly designed for internal Seattle communications at this point. And thank you to the people who put in their emails to contact. I did write them down, and I will reach out and see if we can come up with some other things. And I would say this too to the home health nurses that are on the call. If you want help with diabetes education, or you want some resources, we're happy to connect with you and get you those. You can also check out seattlechildrens.org on our endocrine website. There are a huge ton of resources there for diabetes management, including a bunch of videos that you can watch on how to do ketone management and, some of the basics of diabetes. Pretty much our entire diabetes education in a video format is available to you. It is a little bit difficult to find, but it is there. And as well as most of our handouts that we give to our patients are also there. PDA training. PDA training is parent designated adults. This is a community training that we offer free of charge to school nurses and parents in the community. This time of year, we tend to offer it every other month, and then we ramp that up to once a month, if not twice a month during the school months, to make sure that that people are trained for the school systems. It is free to at Seattle Children's. That may change in the future, but right now it is a free resource. We do have some people in the community who will charge, but who will come to your school to do that training. So we can also get that list to you if you want to reach out for that. Any final thoughts? Love the questions. Thank you so much. I'm going to take the time to write down some emails, and I will reach out to you. It's been a true pleasure, and maybe we'll see you again next year.
Thank you, Joy and Chin. We really appreciate your presentation today.